Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. I've got three very interesting cases, and this is case one, and I'll give you the backstory. So this patient had gone somewhere because they felt that they had earwax, and the place that they went to, I disagree that they should be performing earwax removal in the first place. And this patient had been using loads of drops prior to going to the point. So they felt as though if there's wax, to put drops in and the problem would dissipate. And the main complaint was a dull pain in their ear. And they went to this place and they looked in the ear and says, they quite rightly said, you've got all this kind of residual soft wet wax, but it's not blocking the ear. That's not going to be causing the symptoms. The patient did have a bit of a cold at the time, and he was advised that the symptoms are very likely to be because they've got a bit of congestion. So this patient then arranged an appointment with myself, and immediately I saw this raised area on the posterior inferior quadrant on the osseous portion of the ear canal, the bony parts. This is probably midway, so the pars media. And whenever I see a puffed up area of epithelial skin, we want to know what's underneath it. And we had this very hardened keratin, which potentially may be a canal cholesteatoma. That's what I was thinking at the time. And with the suction, it was extremely hard to remove. It was rock solid. So I reverted to the right ear pick and I managed to prise this away. So this patient has subsequently been seen by ENT, who also feel this is very likely a canal cholesteatoma. They applied loads of antibiotic cream in this area, and they're going to follow up this patient, see how they respond, and also going to refer for CT scan. So you can see I'm really struggling to lift this. And surprisingly, it wasn't uncomfortable for the patient. I was a bit worried because they reported a dull pain upon attending. But so this is where I get the right ear pick, and I'm just going to get underneath and lift away. So there is an ulceration, the underlying bone is exposed. There we are. So I've managed to lift it away. And it was really embedded there. So there will be some local bleeding after I remove this. You'll see that. At the moment you can't see it, but because this was adhered to it and the bone is exposed, there we are. But it wasn't bleeding in the sense where it was pouring out with blood. It kind of stopped bleeding almost immediately. So I'm just mopping up the area around here. And there you can see the erosion is quite a large erosion there. And that's where the bone is exposed. So hopefully, if it is a canal cholesteatoma, it's very early stages and it hasn't spread underneath the posteriorly to the mastoid bone or inferiorly to the temporal bone. And I'm just going to use a fine end, just mop up around the edge, just to make sure you can see there's a bit more skin there to the left. I'm not going to try and get every little piece of skin out. It's just these areas of concern. So another possible reason for an erosion like this potentially could be benign osteonecrosis. That typically occurs on the floor of the ear canal, and it's secondary to poor blood flow. So patients with hypertension, for example, the inferior canal wall receives an inadequate supply of blood, so the bone begins to necrose, begins to decay, and it erodes, and you get sequestration where the bone separates, and you get a ditch forming. So this is, I would say, it's not inferior, it's posterior inferior. So, but that's one possible cause. Typically, with a benign osteonecrosis, the epithelial lining of skin is still present, not always, but normally. Here, there's an ulceration, so the skin is ulcerated and the bone is exposed. So I'm not sure if it is a benign osteocrosis, but that's something for ENT to kind of investigate further. You can see there's a big ditch there, and the problem now is that it's very likely that this area is going to keep collecting with dead skin. So as the skin migrates, it kind of falls into this trench that's created there. I just want to see what's underneath there, because you can see there's a bit, the ear canal's a bit bumpy here as well. Just approaching the eardrum there, so kind of all the areas of concern I'm happy with now. Everything else is just a bit of residual soft wax, because this patient did apply a lot of drops, he said, prior to visiting the previous place. So just clearing out any left behind debris. So I'm just kissing the surface there. And it was all very comfortable for the patient, which is great. So I will follow this patient up with you guys once I hear back further. And hopefully it's nothing too serious. So this, again, is a patient who went somewhere and reporting a fullness in their ear, not being able to hear, and they were told that the eardrum is normal. As you can see, it's not normal. They've got otitis media with effusion, so there's a fluid buildup behind the eardrum. It looks sterile, so it doesn't look infected. This patient hasn't got an upper respiratory tract infection, so it's not acute otitis media, which typically occurs secondary to an upper respiratory tract infection. So because this patient is an adult and it's unilateral, they may possibly, and we have to rule it out, so again we refer to ENT, a nasopharyngeal mass, so a tumour in the nasopharynx region, which obviously needs exploring. So I've done a priority referral, or I've requested that from the patient's GP. So this patient the advice was just to, obviously the eardrum looks normal, so you need a hearing test, although again there was asymmetric hearing loss, so it's only this side. So whenever there's asymmetry in your hearing, that's another reason to refer back to the GP for ENT referral. So because we know that's not likely to be presbycusis age-related, because that's normally symmetrical in both ears. So this is a patient, is actually a father of a friend of mine. I first saw this patient back last year, October, and they had granular laryngitis, so there's granulation tissue on their eardrum. They had previously undergone a tympanoplasty, so a repair of the eardrum. There's a cartilage graft posteriorly, and everything was fine. But back in October, it reported his ear discharging, and so as well as the granular laryngitis, there was a lot of keratin embedded in the posterior superior quadrant of this patient's eardrum, which you'll see is very retracted. And it was discharging back then, so we did a priority referral to ENT. It was seen very, very quickly, and had some topical antibiotics applied onto the eardrum because of the granular laryngitis. By the time they were seen, there was a bit more keratin buildup, a bit more discharge. That was cleared, and the patient was sent for a CT scan and an MRI scan. Now, the CT scan suggests there may be secondary acquired cholesteatoma, potentially after the operation. MRI scan came back clear. It doesn't suggest there's any cholesteatoma. So this patient is still under investigation and may have to go under an exploratory operation, possibly according to what they've advised. So yeah, I hope you enjoyed that trio of interesting cases. And yeah, enjoy the rest of your day. Thank you. Bye.